Hi everybody. I'm Dr. Martins-Welch. I'm a palliative medicine physician working at Northwell Health. I work in the medical oncology cancer setting, and I have been involved with the medical cannabis program since 2016. So I've seen a lot of changes in the program over the last 5 years and have certainly learned a lot. And so I'm happy to share some basic information about medicinal cannabis with all of you today. So the title of my talk is Medical Marijuana, What We Know and What We Need to Know. I have no disclosures. So the objectives of the talk today will be to understand the history of medicinal cannabis, to review the basics of the human endocannabinoid system. I will review the major phytocannabinoids, and I will go over their medicinal properties, as well as looking at some of the evidence for cannabis's therapeutic effects, and of course, review the New York State Medical Marijuana Program. So as of the most recent election, there are now 33 legal medical marijuana states and DC. And then there are, of those states, 11 of them actually have laws that legalize recreational marijuana as well. New Jersey, our neighbor, just was one of the more recent ones to go recreational. I get a lot of, skeptics who come my way, both from the medicinal, the healthcare community and the patient community about, well, isn't cannabis or marijuana dangerous? Can't I become addicted to it? And the answer that I usually give is, when you compare it to other substances of abuse, its risk profile is actually much lower. And this chart actually shows how much it would take to really put someone at high risk for a fatal effect, which really there have been no reported cases of any fatalities directly related to cannabis. Whereas you can see the risk with something like alcohol, it doesn't take too much to become to get alcohol poisoning. So all these substances of abuse have a much higher risk profile when compared with marijuana. And so that's important to note. So what is cannabis? It's a genus of flowering plant. It's native to Asia and has 3 subspecies. These are known as sativa, indica, and ruderalis. It produces over 400 chemical compounds, 65 of which are unique to cannabis and are known as phytocannabinoids. The phytocannabinoids of most therapeutic interest are known as THC, tetrahydrocannabinol, and CBD, cannabidiol. Marijuana is made from a mixture of dried and shredded flowers of the plant. And when we hear other names for marijuana, it goes by many names. I tend to refer to it honestly as cannabis because that is the scientific name. So that's how you'll hear me refer to it during the course of the talk. So this is an important slide because it outlines all of the different components that come from cannabis itself. We have the 2 major phytocannabinoids, which I've mentioned already, the THC and the CBD. And then there are a bunch of minor phytocannabinoids as well. Less is known about their therapeutic benefits, but I feel like the medical literature is growing on a regular basis in terms of we're learning more about what the minor phytocannabinoids can actually do. The terpenes are what give cannabis its aroma. It's a pretty unique aroma if you've ever smelt it. And they also contribute to its wellness effect. And then we have other agents like carotenoids and fatty acids, and vitamin E, triglycerides. So this is sort of what makes the whole plant come together. This is just a little bit of a scientific slide showing the THC and the CBD in their structures, and they're pretty similar in structure. So how does this relate to the human body? Phytocannabinoids have pharmacologic activity, and this wasn't discovered until the 1990s that they actually have a receptor-based effect on this system in our body called the endocannabinoid system. And there's also other ways that it works in a non-receptor mediated fashion. And this is a very recent discovery in terms of how long marijuana has been around. So it definitely was an exciting discovery. And I think there's still a lot of ongoing research going on to figure out just how we can use cannabis to promote therapeutic benefits. So I want to step back and look at the history of cannabis for just a minute. So cannabis is by no means a new, novel drug. It dates back as far as almost 3000 BC into ancient China, where it was used back then as a popular medicine. It migrated over to ancient Egypt by 1200 BC, and India, where they were using it mixed with milk for a medicinal substance. And later it was found in ancient Greece. Speeding up to more recent history, in the 1500s, the Spanish brought cannabis to the Americas. In the 1800s, Sir William O'Shanassy researched cannabis in India, and so he was well known for contributing to early research on cannabis. And in 1850, it was actually classified as a legitimate medical compound in the United States Pharmacopoeia. When we get to the 1930s, there was a strong campaign against marijuana, and many of you might have heard of the film called Reefer Madness. This was intended to scare American youth away from using cannabis. In 1937, the Marijuana Tax Act actually banned cannabis use and sales, and later in 1970, the Controlled Substance Act classified cannabis as a Schedule I substance. This is still in place today in 2021. Harry Anslinger is largely the pioneer of cannabis prohibition in the United States. He was the first director of the Federal Bureau of Narcotics, and he launched this vigilant campaign against cannabis. And so the term marijuana actually was used in place of cannabis in order to make it seem like a more foreign substance. There was a lot of racist undertones in the propaganda against marijuana. So let's get back to the science. So the endocannabinoid system. So this is a network in the nervous system that regulates the transmission of nerve cells, so neurons, and it can either excite or inhibit nerve signals. We produce our own cannabinoids. So these are termed endocannabinoids. So we naturally produce these substances and that bind to our endocannabinoid system. And they interact with both receptors as well as neurons and immune cells. What it does, it helps to reduce excess nerve activity as well as suppressing inflammation. And it functions in parallel with other nervous systems in our body. So again, as I said before, this is a very recent discovery, as recently as 20 years ago. So there is still so much to learn about the system, but what's fascinating about it is how the marijuana, the phytocannabinoids from cannabis actually work on the same system that's already in our bodies. So the endocannabinoid system in our bodies is made up of three main components. We have the endocannabinoids. These are terms anandamide and 2-AG. Ananda is actually Sanskrit for the word bliss, which is said to be sort of what anandamide produces in our bodies, a state of bliss. There's receptors, CB1 and CB2 are the main ones. And there's regulatory enzymes. These enzymes help to make the endocannabinoids and then break them down. So this just shows that we have the phytocannabinoids that are plant origin. So they come from the cannabis. And again, I'll be focusing on THC and CBD for this talk. And we have our own endocannabinoids in our body, 2-AG and anandamide. And they both sort of work on the same system together. So we have our CB1 receptors, and these help, our endocannabinoids and the phytocannabinoids actually bind to these receptors. And the CB1 receptor is really distributed throughout our whole brain in various areas. What's important to note here is that you don't find CB1 receptors on the breathing center of the brain. And that's a real distinction from opioids, where if you take too much of an opioid, for example, morphine or oxycodone, it can suppress breathing because it binds to areas in our breathing center that will make the breathing slower. And hence, that's really what causes fatal overdoses. Marijuana doesn't do that. There are no receptors, no CB1 receptors in that area of the brain. So it really is largely what contributes to its low risk profile in terms of, there being no fatalities associated with high use of cannabis. The human endocannabinoid system is sort of nicely laid out in this slide. I like the picture on the right that shows the distribution of the CB1 receptors, which is mainly, you can see, in the brain and along the spinal cord. And then our CB2 receptors, which are mainly in the immune cells of the body. So they don't have the same sort of effect as the CB1 receptors. And we have here in the middle the THC and the CBD. So these are our phytocannabinoids that sort of work like a lock and key mechanism with our innate receptors. So what are some of the medicinal effects of cannabis? So this was a paper published 10 years ago that looked at why people reported using cannabis. And the top reason was for pain relief, which I think sustains itself today. Most people I speak with who are using marijuana for medicinal purposes are using it for pain. But many also use it for sleep, almost 3/4. To relax. And then other reasons for use are muscle spasms, anxiety, stimulation of appetite, nausea, and depression. In my practice working in palliative oncology, I tend to put patients on medical cannabis mainly for reasons of pain relief, appetite stimulation, nausea relief, and as well as anxiety. So these are some of the potential therapeutic benefits of cannabis overall, and it covers many different, a whole array of issues. So the pharmacologic effects of THC, it's important to note that it is psychotropic, meaning that it can cause intoxication. So this, and I always explain very thoroughly to patients who I'm putting on cannabis that this is something that we have to be aware of and dose accordingly in order to try to avoid having that sort of effect, because the vast majority of patients who are coming to me for cannabis are not looking to get intoxicated, but rather they're sick and they need symptom relief. They want to improve their quality of life. So it's important to know that at a certain dose, they may feel this euphoria and sedation effect. So, we want to make sure that we dose very low and go up very slowly to get to the therapeutic benefit rather than getting to any intoxicating benefit. It also works as it affects the immune system in certain ways, which is outside the context of this talk. The cardiovascular system can be affected. So I tell people if you take too much and it's a little bit too heavy for you, it might cause some palpitations. You might feel a little sweaty. So that's important to realize. But the three bottom parts are the most important for my practice, meaning that analgesia, so pain relief, it works as an anti-nausea medication, and it also stimulates appetite. As far as CBD, though, this is a different type of phytocannabinoid in that it does not cause intoxication. In fact, many of you might know CBD because it's legally sold over the counter online as a hemp-derived product. So hemp, by definition, it's in the family of cannabis, but it has less than 0.3% of THC, which makes it legal for sale. And it's sold for a multitude of properties, many of which are not actually scientifically proven. So I always make sure patients are aware of that. This is sort of, buyer beware. It can certainly help with some indications, but I think there's a lot of overarching advertising that is not exactly scientifically accurate. Nonetheless, CBD is known as an anticonvulsive, and that actually has good data supporting it. And recently, there was a medication called Epidiolex that was approved by the FDA for treatment of pediatric seizures. It is a CBD, really high dose CBD derived from cannabis. and it's being sold by the it's approved by the FDA and being prescribed for pediatric seizure syndromes. It can also help with analgesia, pain relief, and that I think is largely to do with its anti-inflammatory properties. A lot of pain is inflammation driven, so if we get at the cause of inflammation, hence we have better pain relief. CBD does a lot for anxiety, and a lot of this is anecdotal. There's not, like I said before, there's not a lot of data to prove it, but certainly I have a lot of patients who use just over-the-counter hemp-based CBD for anxiety. There are some cannabinoid medicines already out there, FDA approved, that are being prescribed to patients, and I think it's important to note that. Dronabinol is a Schedule 3 substance that's classified as Schedule 3, so it is a controlled substance. It is not derived from cannabis, so it's very important that we note that it's a synthetic compound made to look like THC in the body. It's been approved since 1985 for chemotherapy-induced nausea vomiting, and it's been approved since 1992 for anorexia, loss of appetite associated with weight loss from AIDS. Nabilone is another medication that's also used for chemotherapy-induced nausea vomiting. I can tell you myself, I don't really use these medications very much in my own practice because I tend to put patients on the actual cannabis oil, much preferred, honestly, because you get more of the beneficial effects without so much of the sedation that can come along with the synthetic THC. I'm going to just skip the next for time. So the entourage effect is known, it's commonly referred to in cannabis medicine. And what this means is that the sum of the parts of all the different parts, that, remember that slide I showed at the very beginning that showed the breakdown of the ingredients in the cannabis plant, all those things together work in collaboration for a more enhanced response rather than if you were to just give a single isolate. And you'll see that a lot when you look at, for example, the hemp-based CBD. Is it an isolate or is it a whole spectrum product? And that's what we're talking about here. Do you have the terpenes and the carotenoids and the fatty acids in there as well? Or is it just a single isolate of the CBD? The thinking is that, when you have the whole product, the whole spectrum of ingredients together, you have what they call the entourage effect, which is just a better result, a therapeutic benefit. So some factors that influence the effects that cannabis has on the body. The dose of cannabis that's consumed, of course, it's going to be a very different response if you're taking 2 milligrams of THC versus 20 milligrams of THC. The ratio of the various cannabinoids in the product. So, you have THC and CBD in combination. Are you taking a THC predominant product where it may be a 20-to-1 ratio, or are you taking a 1-to-1 balanced ratio product? The route in which you take it. So if you were to vaporize it, with one of the electronic cigarettes, the time to action is much quicker than if you were to take it in a capsule. How long it's been since you consumed it, the health status of the patient. My young, healthier, more physically active patients can probably handle a higher dose than my more frail, debilitated patients. How old the patient is, although I've had some elderly patients who can really take quite the dose of THC without batting an eyelid. So sometimes people just surprise you like that. Of course, the co-administration of other drugs and medicines. It's really important that when we're putting patients on medical cannabis, that we're reviewing all of their medications to make sure that there are not going to be any concerning drug-drug interactions. If they're already on a plethora of different medications that can be sedating, which many pain relievers are, we need to be very conscious of that fact and guide patients appropriately. And whether or not the patient has already been using cannabis. So when I'm first putting a patient on cannabis, they're coming to me for certification. I'll ask them, are you using any products already? Have you been smoking? Because I've had patients who've come to me who've been smoking for 40 years. So I almost try to tell them not to go with the program because they're going to have to buy a boatload of of products in order to really have much of an effect, because their tolerance level to THC is going to be very high, as opposed to the patient who may have never ever tried marijuana in their whole lives. And we really want to start very, very cautiously with them, because they have no prior experience with it. So history of cannabis use is very important to assess. As far as contraindications to use, so there aren't many, but absolute contraindication would be an acute psychosis or an unstable psychiatric condition. So if the patient has a history of schizophrenia or schizoaffective disorder, they have delusions, they have psychotic events, THC can worsen this. THC can provoke it. We certainly don't want to give THC to patients like that. So I steer away from certifying anyone with a history of psychosis. As far as relative contraindication, and that means that you have to, that the certifying physician has to consider these problems and weigh the risks and benefits of incorporating cannabis. Anybody with severe cardiac disease or immunological disease, liver or kidney disease. So these are case-by-case basis. Cannabis can exacerbate arrhythmias, so you want to be careful with patients who have abnormal heart rhythms. And pregnancy and breastfeeding. In my practice in palliative oncology, I don't tend to see a lot of pregnant patients, or thank goodness. So it's not something I deal with on a regular basis. But I know colleagues who would steer away from having anybody who's pregnant or breastfeeding, simply because THC can affect the neural development in a fetus and an infant, and we want to make sure that we avoid that at all costs. So some side effects of cannabis include distorted perception, loss of motor coordination. People might not be able to concentrate as well. Dry mouth is a big one. I'll hear that a lot from my medicinal patients. Tachycardia, which means a fast heart rate. As I alluded to in the previous slide, psychosis, if THC can induce a psychotic break in certain scenarios. So you want to be very cautious if there's a family history as well. Because there are receptors for cannabis in the gonadal tissues, there's been some correlation with infertility. So that's something to keep in mind in patients who are of childbearing age. Cannabinoid hyperemesis syndrome. So this is something I hear a lot from people who are against cannabis use, and it tends to be, I find a lot of people in the ER who see most of these patients come in and they're having lots and lots of vomiting on a regular basis. The cure for that is to stop using cannabis. I have never seen it in a medicinal patient. It's usually seen with heavy daily recreational users, and it's a very easy fix. You have to stop smoking. And of course, driving. So I always ask my patients, if they drive, if they work, if they operate machinery, it's important that they're counseled on how to safely use cannabis and not to be using it during the time period or before the time period where they're going to be driving or working. I liken it to a prescription for an oxycodone or a Xanax. These are legal controlled substances that we would have the same sort of talk with patients about. So, it's a controlled substance, and we should treat it just like we would any other controlled substance. So I include this slide just so that we understand that there is, and this is from the National Academies of Sciences, Engineering, and Medicine, and they have a chapter in this book, in this report, on the health effects of cannabis and cannabinoids. And so there has been some literature that does prove in adults with chemotherapy-induced nausea and vomiting, oral cannabinoids are effective for nausea. So, that's something that we do have enough data to say it is effective. With chronic pain, there's many different types of chronic pain, but there's a plethora of different types of studies out there and systemic reviews. For the most part, it does help people get better pain scores and helps them use less opioids, which in light of the opioid crisis is a really important thing to note, because if we can try to use cannabis in lieu of, an opioid like oxycodone, that would be beneficial. Multiple sclerosis is another illness where there is a good amount of research done showing how cannabis can help with spasticity and pain. So there is good data supporting that, as well as neuropathy. It's not listed here, but neuropathy, the numbness and tingling, there's some good data to support cannabis's benefits for those as well. So where data is moderate to strong, epilepsy, as I noted earlier, we do have Epidiolex, which is FDA approved, and so there is good data. Neuropathic pain and multiple sclerosis, that's where we have decent data. We don't have compelling data for appetite loss, acute pain, anxiety, insomnia, mood disorders, glaucoma, and opioid use disorder. Now, these are all very common reasons why people use cannabis. It doesn't mean that it's not effective. It just means that the data hasn't, the studies have not been done or compelling to date. And I think a lot of this has to do with the fact that cannabis is not yet legal on a federal level, which leads to a lot of red tape in studying it. Once that that red tape is lifted, we'd be able to better study cannabis and actually produce good data. And I'm sure that a lot more support for many different indications will come out. I do want to touch on the medical marijuana program in New York State. I feel like this is a very important part of the talk as it's relevant to everyone watching. So in 2014, Governor Cuomo passed the Compassionate Care Act, a bill, and this led the way for the initiation of the medical marijuana program in New York State. The program officially launched on January 7, 2016. At that time, there were 5 registered organizations for the whole state. They're all allowed to have up to 4 dispensaries. So that left 20 dispensaries for the entire state of New York. Not a lot. In August 2017, however, 5 new organizations won bids for the production and sale of cannabis, medical cannabis products. So we're up to 40 dispensaries to date in New York State. So what's important to note is cannabis is an out-of-pocket expense. No insurance covers it. Why is that? Because it's not federally legal yet. No health insurance will get involved with a federally illegal substance. So this is really a cash-only program. Not even credit cards are being able to be used in transactions because it's considered an illegal drug deal, I guess. It's a lot of red tape, unfortunately, that the dispensaries have to work under, which make it seem a little bit more illegitimate. But I always counsel my patients that we are certainly following the New York State law, and everything that we're doing is legal. So practitioners allowed to be certifying patients for cannabis have to be either a physician, a nurse practitioner, or a physician assistant, with a current license practicing medicine in the state of New York. And then they have to complete a course online, and that's it. Then they can start certifying patients. As simple as it sounds, we do have a real lack of practitioners who are on the program, who are willing to put patients on cannabis. And I think it's just a lot of fear of the unknown, to be perfectly honest. So the eligibility criteria. So there, initially, when the program first started, there were 10 serious medical conditions that one had to meet the criteria for in order to be registered for the program. These were the 10. About 15 months after the program was initiated, chronic pain was added, and that really opened the doors for a lot more patients to be certified for cannabis. Then PTSD was added, and then later pain that degrades health and function as an alternative to opioid use. So you can see that they sort of widened the net a little bit, because they realized that a lot of patients weren't able to get on the program, and there was a lot of difficulty getting on the program just because of so few practitioners in the state. Substance use disorder was also later added to the program, and that was very forward thinking. And I think the people who are making these decisions at the state level realize that substance use disorder is a serious problem, and if cannabis can be helpful in getting patients off of harmful substances, then we should open up that criterion. So in addition to having one of the serious medical conditions, one also has to have a clinically associated condition. This includes anything on this list. And so most of my patients will get certified for severe nausea, what we call cachexia or wasting syndrome, which is basically the loss of muscle mass and loss of weight, and of course, severe chronic pain. So the approved modes of administration in New York State include a vape pen. So that got a lot of media coverage about a year and a half ago when we had all these vaping related illnesses. I always make sure people understand that none of these products that were implicated in causing the lung issues from vaping were legitimate, like medical dispensary products. These were all black market THC products, with harmful chemicals and fillers in them. So that's important to note because I do have a lot of patients who express concern. And to date, I'm still not too crazy about vaping pens in general. I think it has to be a case-by-case basis. The nice thing about vaping is that it kicks in right away. So if I have a patient with very severe pain who needs immediate relief when the pain comes on, vaping is really the preferred method because it kicks in within seconds. Whereas, with a liquid, it may take 10-15 minutes. And with a capsule, it can take up to an hour to kick in. So, it definitely has to be a case-by-case basis. I just don't think we know enough about the long-term effects of vaping since it is a relatively new thing. So we have to, always keep that in the back of our minds with our younger patients, patients with normal lifespans. Capsules, as I said, are a lot of my older patients, they want to be able to use it like any other medicine. It makes them feel like they're doing, a more legitimate thing. So capsules are certainly an option. I tend to not start there though, because in the beginning, we're still trying to find the right dosing, and capsules do not allow that flexibility with finding the right dose. Liquids do, however. And so I do have a real preference for using liquids up front because that allows us to, you get like a little syringe or an eyedropper and with the tick marks on it that allow for you to measure up a small amount of the oil or the tincture. And then we can administer a little more, a little less, depending on how the body's responding to it. So that really allows the best flexibility with changing the dose around to figure out what works best. Once we find a good dose and we have an idea of what the milligram dose of THC is that is helpful, we can certainly try to translate that into a capsule for more prolonged effect. And there are also sprays, powders, and suppositories. And so ground flower is also being sold in some dispensaries. And so I do have patients who will bake it into baked goods or smoke it. It's sort of ironic that I'm saying that because it actually smoking cannabis and consuming it edibly is considered illegal. So I'm not sure how we're getting around that, but I do have patients using it in these methods and it actually helps very much. So I'm not questioning it, but I think now we're going towards a pathway for recreational legalization. So I think that this is going to be a non-issue very soon. As far as how the time to onset and the duration, so the oil, it says 30 minutes here, but I find just more anecdotally about 10-15 minutes under the tongue, patients are starting to report some effect, and it can last anywhere from 4 to 6 hours, its effects. Vapor, immediate to 5 minutes, and can last a shorter period of time, usually about 2 hours. Capsules take a little bit longer to kick in, as I've said, and they last the longest though. So, for people who really want to just take a pill twice a day, it does make sense. And so this just goes in a little bit more into the routes of administration and, their pharmacodynamics. I'll skip over this. It's a little too complex for this talk. The spectrum, so this is a nice slide that I often will show patients when I'm first putting them on the cannabis program, because it lays out pretty much what the ratios mean. This is taken from the website of one of the New York State dispensaries. And so this is how they color code. Every dispensary will have their own naming system for their different ratios. So we have the green right down the middle where we have a balanced ratio, 1-to-1 ratio of THC to CBD. And that's usually where I start my cancer patients. So it depends on what their main issues are, what they're trying to achieve. But usually in the vast majority of patients I'm seeing for the first time who are coming to me with cancer and symptoms, wanting to start cannabis, we're starting at the balanced ratio. There are some patients who may find that we're going to travel more towards the CBD dominant category. In this case, a blue or even an indigo. And, that will be always determined on a case-by-case basis. I have some patients who will do better with the THC dominant. For example, people who have been using cannabis products, have a bit of a tolerance to it, are really looking to, help with nausea or help with sleep. They may actually be looking for the sedative properties from THC. So we may want to be using a red at night, for example. That's a 20-to-1 ratio. So this is just sort of to give an idea of what the spectrum of products looks like in New York State. So how the certification process works is that the patient has to obviously find a practitioner who is certifying patients, and then do the visit. It can be a televisit or an in-person visit, depending on the practitioner. And then the practitioner will, if the patient qualifies for the medical cannabis program, will then register the patient online, and will print out a certificate for the patient. That certificate is what I allude to as my prescription. We're not allowed to say we prescribe a federally illicit product. So I always make sure that I use the right terminology. It's a certificate. I usually certify patients for a year. Patients can be certified for whatever period of time the practitioner wants to. It could be weeks, it could be months, it could be up to a year. And then the patient has to then go home and register with the NewYork.gov website. And those instructions are clearly printed out for the patient. So it's a step-by-step process. For those who don't have access to internet, it can also be done via phone, although that process takes a little longer. Once the patient is approved, the Department of Health will issue a card for the patient. The patient can also have up to 2 or 3 caregivers assigned. And that means that those people could get a legal caregiver card, because a lot of patients are sick. They're not able to get up and about. And so they can have somebody actually go and buy the product for them, which is a great option for the more frail patients. So this just basically is a cartoon showing exactly what I just said. So what's next? What's down the pike for cannabis? Well, education is key, both of patients, like we're doing today, as well as the public and healthcare providers. So we have a lot of work to do in terms of educating healthcare providers, because more patients than we realize are using cannabis products, but just do not feel comfortable talking to their doctors about that. And that's a problem. So, I mean, people come to this with sort of that attitude from, a few decades ago, where it was, marijuana is the gateway drug that leads to lots of bad things and other illicit substance use. We know that that's no longer the case, to be perfectly honest. It's not any more harmful than legal substances out there. In fact, it can be actually safer than some of our legal substances like alcohol and tobacco. So we need to sort of really heavily work on the destigmatization of cannabis. Of course, federal legalization is huge. And I always tell my patients, until we get federal legalization, it's very hard to be able to refer to the studies that are out there that will hopefully prove the benefit and lead to, I think, better access to cannabis products for medicinal use, as well as just access, to dispensaries and standardization of the products, because we don't have we don't have good standardization right now, and that's a problem. You can get certain products in New York, you go next door to New Jersey or Connecticut, and their medical programs can be vastly different than ours. And so it's a very piecemeal approach to medicinal marijuana. Whereas if we had, a standard program across the country, if you're a medical patient, you can get the same type of product that in California that you could get in Georgia, so that's really what we need to help legitimize the whole process. And of course, as I said, robust studies. We need more studies out there on cannabis and how it helps patients with various maladies. And ultimately, once it's federally legal, we can get insurance coverage for it. That's a huge barrier for many of our patients. They cannot afford to buy this, even if they really would benefit. I see some patients who are in dire straits, and I know how much that cannabis could do for them, but they can't afford it. It can cost anywhere from $100 a month, or much more. I have some patients who spend $400 to $500 a month because they buy various products and really rely on using it in different forms to get them through the day. And not everybody can afford that sort of cost. So getting insurance coverage would be a huge milestone. Our obstacles, obviously, without the validated studies, we don't have the clout. When I say we, I say, cannabis practitioners, cannabis doctors don't have the clout to say that, cannabis can help with X, Y, and Z. The medical community wants to know what the studies show, and robust studies, not just small scale observational studies. And so, as long as cannabis remains a Schedule I substance, we're not going to be able to make much headway. And, for clinical trials and things like that, you can't really properly do a clinical trial with a federally illegal substance. So it's a catch-22. I wanted to give a quick story about a patient of mine from many years ago. Her name was Mrs. B. So I was referred Mrs. B by one of my geriatric colleagues. She was being referred because of severe pain. She had low back pain from her spinal stenosis, which was really debilitating. I think she had undergone, epidurals and other procedures. And at this point, she was very frail and older and really not a surgical candidate. So she was left with this debilitating pain and using a medication called tramadol for it. And she was referred to me for a medicinal cannabis consult to see if maybe this was a better option for her. So the day that she was supposed to come to the office to see me, I got a call from the daughter saying that she ended up in the ER instead because her daughter had found her unconscious. And what she had quickly noted was that the bottle of the tramadol pills, which is an opioid medication, was open, and it came to find out that Mrs. B had taken a handful of them in an attempt to take her life because she was in that much pain from her spinal stenosis and just didn't feel like life was worth living. So the good part of the story is that she recovered just fine without any interventions needed once her system cleared out the drug. And she came to see me the next week. So I put her on the cannabis program. And then this picture was taken at I think it was a 1-month follow-up after she had started taking cannabis. And she was a different person. Her daughter noted to me that she hadn't seen her mom this happy in years. She was using the vape pen preferentially, and this allowed her to get actually many hours of relief. I was really impressed with how long she was able to get relief from the 2 puffs on the pen. And so she was taking it twice a day and doing so well. Still using a little bit of another medication called gabapentin, but stopped the tramadol altogether. I was really impressed. I was 2 months into the program at this point, and I was taken away by what a drastic response in this elderly woman. And I still certify her every single year. She still uses it. We've had to up the ante on some of the other drugs, but she's a real believer. And so I'm hoping that in the future we can see a lot more stories like this one. So in summary, cannabis is rarely, harmful. It's generally well tolerated. While we should avoid it in, patients who are at risk for psychosis and severe cardiac disease, there's good data to show that it does have a therapeutic benefit in certain conditions, and we just need to, continue to see it become more accessible and federally legal so that we can do the proper studies and really increase access to cannabis. And that's my talk on medical cannabis. I'm hoping that it was informative and that you were able to learn the basics and maybe a little bit more. And so if you're looking for more information, you can certainly just Google the New York State Medical Marijuana Program, where you'll see a lot more information about the specifics. Thank you for having me, and have a great day.